Something I forgot to mention on lateral T-spine. Flip over to page 350 or 453. Dyslexia is giving me fits today. 453. What you see is recommendations for lateral T-spine to make sure that you get a good lateral. So, we have a tendency to look at the vertebra on an X-ray as being kind of square, and it's really kind of tubular looking. So, it looks really pretty square, right? But it's really kind of a tube. The body is really more of a tube. So, what you get if you don't put your central ray perpendicular to the long axis of the T-spine or the L-spine, either one, is a phenomenon where instead of it looking nice and square, it kind of looks a little like, you know how when you were a kid you first learned how to draw something that looked like a tube, you drew the two lines and the circles on either end. It starts to look like that. All right, so then it kind of, to the first few times you see it, you think the patient's got something wrong with their L-spine or T-spine. And they don't. It's just that what you're seeing then is, instead of seeing a nice square appearance to the vertebra, you're starting to see the top and the bottom, right? The flat portions of the top and the bottom of the vertebra. And that's a visualization of what a neurosurgeon or an orthopedic surgeon who's trying to do a procedure on the L-spine we call coplanar. So you're probably never going to hear that word except for when you're in surgery. It's not on test. It's coplanar. It's spelled just like it appears. And so if you're ever in surgery and you're doing a procedure and they've got the C-arm across the patient, or really going under the patient, they're getting ready to do a spinal fusion, and the doc is looking at the image and he says, "You're not coplanar." What he's saying is you're not good in lateral. So if you look on page 453, what you see on lateral T-spine is you've got two options. One is to make sure that the T-spine is parallel to the image receptor, and if it's not, then angle your central ray perpendicular to the anatomy. So what that looks like would be, first off, take a step back and look at the patient's spine. You can always tell where somebody's spine is because, you got that fold in of the muscles to get to the spine's process. So take a look at the spine and either build it up until it's parallel to the image receptor, parallel to the tabletop, or angle the central ray until it is perpendicular to that anatomy. So the book says that you angle 10 to 15 degrees cephalic, and the difference between those would be the difference between male and female. Men with broader shoulders, you need a greater angulation. Women with more narrow shoulders, you need lesser angulation. But I'm going to tell you, some people are just shaped like a tube, So, and I said that one year, and I had a student. She said, "Yep, that's me." And she was great. She wasn't embarrassed by it or anything. Yeah, that's me. So, so take a look at the patient before you marry yourselves to the 10 to 15 degrees. Take a look. Take a step back, take a look at their spine. If you don't need angulation, don't put angulation on it. If you need to build them up, build them up. If you don't need to build them up, don't build them up, right? So look at the spine and try to gauge how much of an angulation you would need, or whether or not you would even need to build them up. Okay, so that's 10 to 15 degrees is the test question, test answer, 10 to 15 degrees, 15 degrees for men, 10 degrees for women. We're going to see that again when we get to the L-spine. We're going to have to angle in the opposite direction, greater angulation for women than men. So right now we're going to skip to page 482 and talk about lateral bending. That's where we left off. Lateral bending, we're going to do some two different things as fusion series on L-spines. So this is one of the few, with L-spine, you can't have an AP in a lateral L-spine, but lateral bending would be a variation of just two APs. So what we're going to do with lateral bending is and if you look in your book, they've done a really good job in this edition of the book showing what lateral bending should look like. And what we have a tendency to do is to have the patient bend but a lot of the bending and the rotation comes from kicking the hips that way, right? You don't really want that. What you're trying to assess, you know, if you tell the patient, I want you to bend as far as you can, reach for your knee on the left-hand side, then what they're gonna have a tendency to do is kick their hips out to the right, okay? That's not really showing what the mobility of the T-spine is. So what you want to tell them to do is keep their hips where they are, keep the knees where they are, and just bend in one direction. Make your exposures an AP, and then bend in the opposite direction, make an exposure. And what we're looking for is, again, spinal fusion. It can also be used to assess mobility in patients who have scoliosis. So those two cases, we would use lateral bending. We're also going to do flexion and extension, just like what we did in the C-spine. But that's going to be lateral, and we'll get to that in here in a bit. Okay, so L-spine, we've talked about a lot of this. Lateral L-spine. Okay, so where I've seen the positioning error with lateral L-spine is in also where to put the central ray. In a lot of cases with the L-spine, people would position too far posteriorly. Okay, they look at the butt, they look at the back, and they position too far posteriorly. T-spine was generally too far anterior. L-spine is generally too far posterior. So what we're going to do is, again, roll the patient up onto their side. Keep in mind, you may need to include the sacrum and the coccyx. Know your routine, but most of the time it's going to be L5, really T12 through S1. Okay, so roll the patient up into a true lateral, put their knees on top of each other, their ankles on top of each other, arms out in front of them, get them rotated up without, into a lateral without any kind of rotation. Now, can you see this light area right there? Kind of goes up and it comes down. That's the iliac crest, right? So where is the highest portion of the iliac crest?
L4.
Okay, it's at L4, but it's right at the posterior body, right? Okay, so then we've got, we've got the pedicles here, and then we've got the lamina, and we've got the spinous processes sticking right out about here. So where would that be in reference to the vertebra, the entire vertebra, including the spinous processes? Dead square in the middle, right? So what you're going to do is you're going to rotate the patient up, and you're going to feel for the highest part of the iliac crest, and you're going to put this line of collimation straight up and down from that. And you're really not going to see the spinous processes very well on the lateral. That's okay. You're probably going to, I think this is an old film radiograph, so you're probably going to see them better than this. They're still not going to be ideal because the bone here is much more dense than the bone back here. But put this line of collimation, your longitudinal line of collimation, going straight up and down from the iliac crest. And then depending on what it is that you're shooting for, you can either shoot at the iliac crest, or you can shoot 1.5 inches, 2 inches above. So if you're going just for the L-spine and to see the top of the sacrum, then it will be 1.5 inches above. If you want to see the sacrum and coccyx, you may go at the crest itself. Again, 40 inches could be 48 inches. I'd say that most of your techs are probably going to be using 40 inches. Textbook says 48. Okay, you could even go higher than that if you wanted to. So that's another mess, but we already drew that on the board. Okay, so flexion and extension L-spine kind of follows the same rules. We've already got the patient in a lateral position, and now what we're going to do is have the patient bend forward and backwards. And again, what we're going to have a tendency to do is to tell the patient, I want you to reach over and touch your toes. But where is that most of that flexion coming from? I'm not even going to try to, but if I reach down and try to touch my toes, where's that coming from? Hips. The hips, right. So again, it doesn't really assess, the mobility, of the vertebrae themselves. It assesses the hamstrings more than anything else, right? So what you're going to do is you're going to have the patient, you know, in a true lateral position. These I shot mostly upright. And have the patient just slouch as far as they can. It's kind of like doing a crunch, right? So have the patient kind of do a crunch. Make sure you get their arms out of the way. Do a crunch, make your exposure, and then if they need the arms to support themselves when they lean back, again, don't have them do a pelvic thrust, but have them put their hands kind of on their hips and lean back as far as they can for the extension. Okay, so 2 laterals, again a fusion series. Both laterals, true laterals, just one with flexion, one in extension. It shows fusion post-op. So they become a little bit more difficult to photo time. So if you happen to be doing a full series, or maybe an AP and a lateral with flexion and extension, what I recommend that you do is make your exposure on the lateral. Notice what mass you shoot with on the lateral and set that technique for the flexion and extension. The problem with the flexion and extension is that the photocell doesn't move, but you're going to be moving the patient throughout the photocell, right? It becomes much more difficult to phototime it. So set your technique for the flexion and extension if you shot a lateral. So yeah, that's just not right. Both of those really just don't show us what we want to see. You know, I mean, we're going to see some mobility there, but it's just, you know, I mean, most of what she's got there, and good for her, she can touch her toes, right? But that's mainly showing again how flexible her hamstrings are, and you know, most of that rotation comes from the hips. Okay, so lateral. You got your lateral. And sometimes you can't see through L5S1 well. All right, so now we're on page 464. I can read that one frontwards and backwards. 464. So sometimes you can't see through L5S1 well. And the demographics on this are usually thin women, right? So, you know, the female pelvis is more broad than the male pelvis. So you got a thin woman and you shot a lateral L-spine on her, and because of the broader hips, you just can't see through L5S1 very well. So we can do what we refer to as the L5S1 spot. And generally, the way people will do this, I'm trying to get my patient right for me here. There we go, there we go. So, you know, the patient's up left lateral, facing away from me. What I'll do is take my left hand and I'll push it into the soft tissue directly above the crest. All right, so I'm right here. And then I'll fold my hand down over her hip like that. And you see where the thumb and the forefinger kind of make that, it's kind of like a V. It's an inverted V. But you're going to put your crosshairs right there. Okay, so if you didn't build the spine up, then you would angle your central ray 5 degrees caudad and collimate down to just almost nothing. I think the book says 6 by 6, but you can go 4 by 4, and it'll put it right through L5S1. Okay. And that's what you're looking at on page 465. So when do you use the L5S1 spot?
When you can't visualize L5S1.
Exactly, when you did your lateral and you can't visualize L5S1. So flipping back over to page 463, on your lateral, what you're going to do is, again, build the spine up. And if you don't build the spine up, step back, take a look at the patient's spine, and you're going to angle your central ray 5 to 8 degrees caudad. 5 degrees for men, 8 degrees for women. If you don't see L5S1 well, then you do your L5S1 spot. Those are becoming more rare because of the sensitivity of and the dynamic range, the contrast levels that we can see on a digital image. Okay. that. Okay, so now obliques. All right, so again, bilateral obliques, it can be AP, they can be PA. Doesn't matter which way you go with it. Most of the time, people are going to be shooting AP. So what we're going to do is we're going to rotate the patient 45 degrees in either direction, and the central ray is going to enter about 2 inches medial to the elevated ASIS. So you know what the ASIS is? It's that bone that sticks out the front. So as I rotate the patient up, what you should see is we've got spine, and as I rotate the patient up, look what happens to the distance between the ASIS and the vertebra, right? So over there you can't really see. If I rotate that way, look at the distance, how much it changes as I rotate the patient up, right? It decreases. So what we're going to do is we're going to find the ASIS and we're going to go 2 inches medial to that. Okay, that's not your central, the center of your central ray. The center, your centering is still going to be just like what it was on lateral, and that is 1.5 inches above or at the crest, depending on if you want to see the sacrum and coccyx. So 1.5 inches above the crest, but that longitudinal line should go about 2 inches medial to the ASIS. Does that make sense? Kind of gets some blank stares. So that's your obliques. Both obliques, both 45 degrees. What you might see in clinicals is that the lower the L spine, they may decrease that angulation to like 30 degrees. So what we see then is probably the not the hardest thing to remember, but it is probably the hardest thing to see and the hardest thing to wrap your mind around, is that on the obliques, what we see are, again, the zygapophyseal joints. And somebody looked at this at one point and they said, well, that, you know how you look at the clouds and you see shapes? Somebody looked at this and said, well, that looks like a Scotty dog. So what a Scotty dog, or the parts of the Scotty dog are, you can kind of figure it out even if you can't see it in the image itself. But as we rotate the patient up, look what happens to our transverse processes. So you're looking straight on them here, right? So they're both sticking out equally, and as I rotate up, this one sticks out more and this one sticks out less, right? You'll see that over there. It goes from here, spinous processes, sticks out more. This one hides behind the vertebra. Has everybody seen that? Okay. So the spinous, or the transverse process, forms the nose of the Scotty dog. So that's what you're seeing right there. In a perfect oblique, that nose should come right to the edge of the vertebra. If it's tucked in further, then that means that you're too lateral. If it's sticking out from behind the vertebra, you're too AP. So the nose forms or the transverse process forms the nose. The pedicle, that thing right there, is the eye, and what we're looking at there is we're looking straight down onto the pedicle. Okay, so the eye forms the pedicle, and then the neck is what we refer to as the pars interarticularis, and then everything back here just becomes kind of a mess. So what the Scotty dog, the significant parts of the Scotty dog, in as much as what we want to see, and that's dependent on accurate positioning, is the zygapophyseal joint. So the leg of one Scotty dog articulates with the ear of the Scotty dog directly below it. And between those two things, what we get is our zygapophyseal joint. So the dark lines represent the zygapophyseal joint. Okay? So can anybody see a Scotty dog? Ish, yeah. Yeah. If I gave you some heavy drugs, could you see that?
Probably.
Maybe then, yeah. So, you know, if you don't see anything that really looks, somebody told me one year that it looked more like a, you know, those curly shoes that Shriners wear. You seen those?
Mm-hmm.
Yeah, I think, or the elves, right? It looked like an elf shoe. I see Scotty Dog a whole lot better than Scott. I don't know what she was thinking. Anyway, so that's kind of drawn in for you. Scotty Dog. Okay. All right, so L spine fractures, mainly subluxation. Now spondylolisthesis is a subluxation. A spondylolisthesis is specific to L5S1. So what we have then, most of the time it is anyway, what we have then is a partial subluxation between the two. And a lot of people have it and they don't know it. And it's not all that big of a deal. It may cause some back pain, but in as much as causing paralysis, it's probably not going to unless it gets pretty severe. And that is because your spinal cord ends around L1. Okay, you still have nerves that come off, but your spinal cord itself ends a whole lot higher than that. So you may have some nerve impingement, you may have some nerve involvement, but it's not as severe as what it would be if you had subluxation at T12 L1, right? We can also have compression fractures at L spine as well. That would be a compression fracture. That would be the subluxation of spondylolisthesis there. It looks ugly, right? First time you see that, you're going to think, how is this guy walking around? He had no idea he had that, most likely. So if you have sacralization, what you may have is the L5 may be at more of a wedge shape, so that it looks like it belongs on the sacrum. And again, that would be a transitional vertebra. Okay, so SI joints, we've got a few things. We're going to do AP axial and AP oblique. I don't know that I've got the Ferguson method in here. Ferguson method is represented in your textbook on page 466. So 466 calls for a 30 to 35 degrees cephalic angulation, 30 degrees in men, 35 degrees in women. And the positioning, okay, central ray enters mid-sagittal plane at the level of the ASIS, okay? So that's the Ferguson method on page 466. On okay, so on 472 we've got the obliques. Oh, there's Ferguson method. Yeah, I just didn't advance quite far enough. Ferguson method shows us SI joints here. So oblique SI joints. So what we're going to see in the SI joint, if you notice, our iliac bone extends posterior further than what the sacrum does. Right? So it kind of squeezes in on both sides. So it's kind of hard. It's very stable. It's kind of hard to dislocate your sacrum and coccyx from your iliac bones. You got to do something pretty severe to do that. So in order to visualize what's left of the joint space, you got, it's a fibrous joint. In order to visualize that, what we have to do is we have to put the central ray as parallel to that joint space as possible. So we're going to oblique the patient. If we're AP, it's going to be the elevated side, okay? So again, notice what happens between the ASIS and the SI joint as I rotate the patient up. It decreases, right? So we have less of a distance between the two. So that's going to be your reference point for where you're going to put your central ray. So we're going to do bilateral obliques. AP, you're going to show the upside, so LPO and RPO are going to show the side elevated. Our degree of obliquity is going to be 25 to 30 degrees with our central ray 1 inch medial to the elevated ASIS. It's going to look like that. So coming. Doesn't really look like your traditional joint space, right? Okay, so sacrum and coccyx, sometimes docs will order both sacrum and coccyx at the same time. Sometimes they'll just order one. If they order both of them at the same time, the lateral can serve for both sacrum and coccyx. If I forget what I was going to say. Okay, so lateral sometimes can serve for both. Okay, so your apiaxial is going to be apiaxial, and your central ray for the sacrum, sure I don't tell you backwards, is going to be 15 degrees cephalic, and it's going to enter 2 inches superior to the symphysis pubis. Okay? So what's the distance between symphysis pubis and the ASIs?
2 inches.
It's about 4 inches. It's about 4 inches, right. So 2 inches above the symphysis pubis is going to be the same thing as
2 inches.
2 inches below the ASIs, right? So again, just don't recommend you palpate the symphysis pubis. Just go 2 inches inferior to the ASIs. Okay, so 15 degrees cephalic, 15 degrees caudad if the patient's prone, 2 inches superior to the symphysis pubis, but you do 2 inches inferior to the ASIs. Okay. So then if we're shooting a coccyx, then our angulation is going to be 10 degrees caudad, and the entrance point is going to be exactly the same, 2 inches below the ASIs. Okay. So sacrum, you're going to have superimposition between the symphysis pubis and coccyx. But you're just looking for the sacrum anyway. What you start to see are those holes in the sacrum more open. You can also see the SI joints a little bit better as well. Coccyx goes in the opposite direction, and coccyx is always difficult to see because patient almost always has air in their rectum. If they don't, they're going to have feces in the rectum, and so it's going to be very difficult to visualize, or more difficult to visualize than what the sacrum would be. Okay. So then the lateral, we're going to rotate the patient up just like every other lateral that we've done before. And if we're doing lateral sacrum, then we can put our central ray perpendicular to a level 3.5 inches posterior to the ASIS. So find the ASIS, just go 3.5 inches posterior to that, and about 4 fingers, right? And the coccyx is going to be 3.5 inches posterior and 2 inches inferior. So if you're shooting, you get an order for a sacrum and a coccyx. For the lateral, just position for the sacrum and open your collimators a little bit to make sure that you include the coccyx. And you can get them both on one. Okay. That looks like that. Even the lateral is kind of tough to see on coccyx. Okay, so scoliosis should be the last thing that we need to talk about. So scoliosis, your demographics are typically going to be young women, and we may have some variations of that, maybe some follow-ups later in life. I had a neighbor at one point that she had scoliosis, and they put rods in her. And the first time you see this, it kind of freaks you out as well. It's odd to see, as they'll put what they referred to as Harrington rods. I don't know if they're still using them or not, but they have these hooks that hook onto the transverse process. They'll put these hooks on the transverse process for the length that they're trying to straighten out. And so they'll put hooks on the bottom, hooks on the top, and then rods in between them just to try to straighten the patient out. And once the musculature, I guess, develops, and the kid's out of puberty or whatever, they may take those rods back out, right? So one day this neighbor came over holding these Harrington rods with the hooks and everything. Look what I got out of my back. And so I try to hand them to me. I'm like, they got meat on it. I don't want to touch that. It's kind of gross. But at any rate, you see that sometimes. So scoliosis series to determine how much lateral curvature the patient has. So what we'll do typically with scoliosis series is if the doctor has the equipment, then they'll make a single exposure that goes at least from the lower C-spine all the way down to the sacrum. All right, so single exposure, long cassette, very expensive. So in a lot of cases what they'll do is they'll do something different that requires multiple exposures. So they'll do one exposure to include the lower C-spine down to the upper L-spine, and they'll take a second exposure to show the L-spine down to the sacrum. And then they have in the computer what they refer to as a stitching program that puts the two together so that it looks like a single image, okay? So what we'll do with the scoliosis series, again, young women with developing breasts, we want to reduce the breast dose as much as we can. So we'll shoot these PA, all right? So we shoot them PA and the body becomes a filter. It's going to filter out some of those low energy X-ray photons before it makes it to the breast. So it's going to be a PA projection, probably at 72 inches, especially if they're going to use the long cassette. It may even be all the way back 10 feet. PA projection, and what they'll use also is a trough filter. And it's not a filter in the same way that we've seen compensating filters. In this case, what they're going to do is use these trough filters as radiation blockers, extra collimators, again to reduce the amount of radiation that's going to pass through the patient, reduce the breast dose. Because again, we're dealing with young women with developing breasts, so we want to reduce that dose as much as possible. So it's usually going to be PA projection, PA and lateral. PA definitely, probably PA and lateral. Rarely are we going to do AP, just because we don't want to have that breast dose. Okay, so if you look on page 488, you see some cases of scoliosis. 486 kind of shows the stitching program or the long cassette. So they can make a single exposure. And just the procedure on page 484. Okay, so any questions? Oh, one other thing on L-spines. So looking at L-spine here, so if I turn this thing sideways, you kind of see the orientation of the disc spaces. They're kind of, they go in one direction, then they go in the opposite direction, right? Can you kind of see that? Even if we bend the patient's knees, we're still going to have a little bit of that. It's just not going to be quite as bad as what it was before. So you're probably going to run into a question eventually that'll say, in order to best visualize the disc spaces on a lumbar spine, which projection would you use? And the answer is going to be a PA, because the disc spaces are on AP, they're going this way, right? So lower is kind of pointing down, upper is kind of pointing up. But what way is the central ray going? How does it diverge? It diverges in the opposite direction, right? So if we shoot PA, they more closely match each other and it opens the disc space better, okay? Now ask me how many times I've ever shot AP or a PA L-spine. Right, but that's probably a question you're going to bump into maybe all the way through the registry. So PA projection opens the disc spaces better than what does AP. Okay. Practical tips on scoliosis series, lateral bending, flexion and extension. Open your collimators up just a little bit more. I don't say that very often, but open your collimators up just a little bit more, just to make sure, especially on scoliosis series, if the patient has some pretty severe scoliosis, and you try to collimate in like a normal T-spine, and you have to go back and reshoot it, again, what's our demographic? Young women, right? So if you have to go back and reshoot it, then what's a radiation dose that you thought you were saving by collimating? Double, right? So, collimate certainly, but don't overdo it, right? Any questions?